and welcome to the August episode of the Axial Spondyloarthritis podcast series. Alongside with our RA and PSA podcast, we'll be bringing you monthly slide decks to help you keep up to date with the latest research and publications in the field of axial SPA. My name is Sofia Ramiro. I'm a consultant rheumatologist and senior researcher at Leiden University Medical Center and Zuiderland Medical Center in the Netherlands. And today I'm joined by Hideto Kameda, Professor of Internal Medicine at Toho University, Xenofon Baraliakos, Professor of Internal Medicine and Rheumatology at the Ruhr University in Bochum, and Medical Director of the Rheumatology Center Rheumatzentrum Ruhrgebiet in Herne, Germany. And finally, Atul Deodhar, Professor of Medicine and Medical Director of Rheumatology Clinics in the Division of Arthritis and Rheumatic Diseases at Oregon Health Science University in Portland. We hope you enjoyed this episode of the Axial SPA podcast. And if you would like to know more about the paper we discussed today, please head over to the Immune-Mediated Inflammatory Disease Forum website at the www.imidforum.com, where you can review and you can have the full slide summaries of these publications. Now, Hideto, I think we have an exciting paper to cover today. Can you please tell us about it?
Okay, thank you, Sophia. We will be discussing one paper today in which the authors investigated the incidence of uveitis in patients with axial spondyloarthritis that were treated with bimekizumab. Now, Xenofon, over to you for background and methods.
Yes, thank you very much, Hideto. This paper is a recent publication from Matthew Brown and colleagues. It's entitled Low Uveitis Rates in Patients with Axial Spondyloarthritis Treated with Bimekizumab, pooled results from phase 2b and 3 trials. For the background of this publication and the study, we know that uveitis is an issue. It is a common AxSpA, axial musculoskeletal manifestation, and it's also there to be discussed also about IL-17. It's implicated in the pathogenesis of axial spondyloarthritis. However, there is conflicting evidence for inhibition of IL-17 in uveitis patients and in the management of uveitis. So the study reports the results of a pooled analysis of uveitis incidences in patients receiving bimekizumab from phase 2b and 3 trials. In the methods, what the colleagues did, there were data on uveitis in patients with axial spondyloarthritis, and they were analyzed from 3 clinical trials with bimekizumab and their open-label extensions. And the BMobile 1 study was a phase 3 trial on non-radiographic AxSpA, axial spondyloarthritis. Patients there were initially randomized equally to receive subcutaneous bimekizumab 160 milligram or placebo every 4 weeks, which then was followed by a 36-week maintenance period where all patients received bimekizumab 160 milligrams every 4 weeks. Then the BMobile 2 trial was a phase 3 trial on radiographic AxSpA now. Patients were initially randomized now in 1-to-2 rates to receive bimekizumab 160 milligrams subcutaneous or placebo every 4 weeks. Also then followed by a 36-week maintenance period where everyone received bimekizumab 160 milligrams every 4 weeks. The B-Moving open-label study, which included patients from B-Mobile 1 and 2, where all patients remained on bimekizumab for up to 2 years, the same dose. And then B-Agile, which was a phase 2b trial on active radiographic AxSpA patients, and included a 12-week double-blind dose-ranging period, followed by a 36-week randomized period with bimekizumab 160 or 320 milligrams every 4 weeks. The B-Agile open-label study included patients from B-Agile, where all patients received bimekizumab up to 4 years in the study. Those that we know, this means 160 milligrams every 4 weeks. Again, the methods, the data were separately pooled for patients treated with at least 1 bimekizumab dose in the B-Mobile 1 and the B-Agile trials, and in their ongoing open-label study. And uveitis events were identified using the preferred terms autoimmune uveitis, erythrocyclitis, iritis, and uveitis, coded according to the MEDRA version 19.0. For simplicity, the blanket terms uveitis is used here to cover all of these preferred terms. The uveitis rates and exposure-adjusted incident rate per 100 patient years are reported, and this is what the publication is mainly referring to. Now, I would like to hand over to Atul, who will speak about the results of the study.
Yeah, thanks, Xenofon, and I'll be sharing the results from this study. And it is a complicated study in the sense that we are combining a phase 2 study, which is the Be Agile study, with this Be Mobile, which is the phase 3 study. And so because of the study designs of these trials, and because of this 2:1 randomization ratio in the Be Mobile 2, which is the radiographic AxSpA, a higher proportion of patients treated with bimekizumab had radiographic AxSpA than those treated with placebo. So 63% versus 46%, 47% of the patients on placebo. So in the pooled Be Mobile trials, which is now phase 3, patients treated with placebo had slightly higher rate of history of uveitis to begin with compared with patients treated with placebo, compared to patients treated with bimekizumab. 19% of the patients with placebo had past history of uveitis compared to 15% of patients treated with bimekizumab. The exposure-adjusted incidence rate of uveitis in the double-blind treatment period, which is weeks 0 to 16, showed that in pooled Be Mobile data, exposure-adjusted incidence rate was lower for bimekizumab compared to placebo, significantly lower. I mean, it's 1.8 versus 15.4. And when I say significant, it is not statistical significance. It's kind of the numbers look pretty drastically different. Exposure-adjusted incidence rates were also lower for bimekizumab in patients with and without history of uveitis. In the pooled phase 2B, which is now Be Agile study, and phase 3, which is the Be Mobile, exposure-adjusted incidence rates for bimekizumab were 1.2 overall, 4.6 in patients with a history of uveitis, and 0.6 in patients without a history of uveitis. As we know, history of uveitis is a risk factor for getting more attacks of uveitis in future. In the pooled Be Mobile data, now we are removing the Be Agile, 0.6% of patients treated with bimekizumab and 4.6% of patients treated with placebo experienced uveitis event, and this was statistically significantly different. In Be Mobile, Be Mobile 1, this is the non-radiographic AxSpA phase 3 study, 1.6% of patients treated with bimekizumab had a uveitis event compared to 4.8% receiving placebo. No patients treated with bimekizumab had a uveitis event, while 4.5% of patients receiving placebo did in Be Mobile 2. This also is statistically significantly different. We also looked at the Kaplan-Meier estimates for time to first uveitis event. When do they get it? In patients receiving bimekizumab in the phase 3 and also in the combined pooled phase 2B and 3 trial pool. And that suggested there was no real trend in time from first bimekizumab administration and the first incidence of uveitis. So those are the results, and I want to pass over to Dr. Kameda to tell us about the conclusion.
Okay, thank you, Atul. So what can we take away from this paper? In conclusion, the incidence rate of uveitis was lower at week 16 in patients with axial spondyloarthritis randomized to bimekizumab 160 mg every 4 weeks versus placebo. In the double-blind treatment period of the phase 3 Be Mobile trials, in a large pool of phase 2B and 3 trial data, the incidence rate of uveitis with bimekizumab over long duration remained low. This suggests that bimekizumab may be an appropriate treatment option for patients with axial spondyloarthritis and uveitis. And this is the first analysis to examine the effect of bimekizumab on uveitis in patients with axial spondyloarthritis. So this is a very interesting study, which has been picked up by TRAG conference analysis in ACL 2023 because the presence of uveitis largely affects on a therapeutic choice for axial spondyloarthritis. Previous reports on IL-17A inhibitors have been conflicting because intravenous secukinumab and subcutaneous ixekizumab showed positive results, but subcutaneous secukinumab was negative. So at present, it cannot be determined that additional inhibition of IL-17F is important or the dosing of the drugs is important. Still, it is possible that increased dose of IL-17A inhibitor, especially for subcutaneous secukinumab, is required for uveitis control. For example, the approved dose for axial spondyloarthritis and psoriasis is different for secukinumab, and we often experience the gap between the improvement of actual disease and psoriasis in the same patient. Now, what's your comments, my colleagues?
Thank you very much, Hideto. I think it's very good to open this up for discussion. And before we start discussing, I would like us to invite us to clarify something which I think we have not mentioned today, which is up to what time point were this analysis conducted? Because we have data from the bimobile phase 3 studies, and the emphasis is put on the placebo comparison up to week 16. But when we have the pooled 2B and 3 analysis, it was not entirely clear until what time point these analyses were conducted. Could you please clarify that, Atul?
Yeah, so it's an important point you raise, because there are several confusing points unless you read the whole paper about this, because we are combining a phase 2B study, which extended up to 5 years. And we are combining this 5-year study with a phase 3 study, which only went up to 1 year. And then more recently, phase 2nd year of that study has been published as well. So if you look at the paper, we are sort of talking mostly, when we say pooled data, that's only up to 1 year for when you are combining pooling of phase 2 and phase 3. But then there is a separate data published about phase 2 study all the way up to 5 years. That's point number one. Second point is B-Mobile 1 was non-radiographic, B-Mobile 2 was radiographic. And yes, ultimately we are saying that this is one single disease, axial SPA, but it is known that patients who have definitive radiographic changes on their on their plain X-ray, that's why they're called radiographic sacroiliitis, radiographic axial spondyloarthritis, they have a higher incidence of recurrence of uveitis attacks compared to non-radiographic. And we are pooling them together when we are talking about pooling of the B-Mobile part of it. So considering all of this, I can see that it is confusing, but to answer to your question, in the pool data, it is 1 year, but then separately, we're talking about B-Mobile 1, separately about B-Mobile 2, separately about only pulling B-Mobile parts of the study and then adding the B-Agile study into that. So lots of things to slice and dice this data.
Yes, definitely. Thank you. But it's good to know that here we are talking about up to 1 year, because I think that can also be important. Indeed, as you were mentioning, in radiographic axial SPA, we see higher occurrence of uveitis, and also with disease duration and symptom duration going forward, the likelihood of having an episode of uveitis is also higher. But that brings, your comment brings me immediately to the next comment, which is, but in the separate trials, there was a difference noted. So it's not that the pooled result is only due to the radiographic axial SPA or to the non-radiographic axial SPA, because actually also in the B-Mobile 2, so in radiographic axial SPA, we see a difference between bimekizumab and placebo, correct?
Yes, there is a difference between bimekizumab and placebo. So the 16 weeks is the only time where you can compare active drug with placebo. That's number one. And so thank you for bringing this up, Sofia, because another complication is then what percentage of people on placebo had previous history of uveitis, and what percentage of patients on bimekizumab had previous history of uveitis, because that also makes a difference. And interestingly here, patients who are on placebo in that first 16 weeks, and I'm talking about B-Mobile, they had a higher incidence of uveitis in the past history. So they were prone to get more attacks also. So that also complicates the picture. I mean, this is a post hoc analysis of these studies, and we are trying to sort of, so these are clearly not matched. In real life, what you would have liked to do is take patients who have similar history of uveitis in the year before, and then in the next year, give them either placebo or bimekizumab. Then at least you would have matched them for their risk of recurrence of uveitis. And here it was different. Here it was not matched because this is a post hoc analysis.
Yes, very good point. And I think we will want to go that to the methodological aspect, to what extent we can translate these results immediately to our daily clinical practice. But just to comment on what you just said, that placebo patients had a higher history of uveitis. So the bimekizumab arms had no cases of uveitis, and the placebo had the cases of uveitis. So there can be here also a difference because the previous history of uveitis, as you were mentioning. Okay,
Yes,
now if we move to the next phase, which is what can we do with this conclusion? So how can we interpret the, as Hideto started in the beginning, with the efficacy of IL-17 inhibitors on uveitis? What can we conclude from the literature we have up to now? What would you say, Xenofon, about efficacy on uveitis in general as a class?
Well, listening to the comments, I think it is still important to think what this study really brings in, adding to your question. So I think we cannot finally answer the question about IL-17 and uveitis for that one study only anyway. It's not an IL-17 inhibitor, it's an IL-17 and F inhibitor, so I wouldn't generalize the data anyway. It was also mentioned very nicely by Hideto before about different doses of secukinumab and so on. But still, I believe these data show that we are not, let's say, when we don't have a drug that doesn't work. Obviously, somehow something is working there. And the big question will always be, is there something, is that treatment with IL-17 inhibition, A and F in that case, much different than the TNF blockers? And again, very, very roughly, top level means I would say no, it's not so much different. With all the caveats you mentioned, especially the 1 year follow-up, which is important because it's not long, and especially also the difference between placebo and bimekizumab, which again has shown differences, but in a very short period of time, which again makes me worry about, very short period of time, so many differences. Why is that? Maybe it is the history. So, but to answer the question again, I think we need more data, as everybody says, but I think it is a positive direction. That's what I take from that study. It's a positive direction to a very big question mark that we have about anything else in a BDMARD field beyond TNF, monoclonal TNF blockers that we have seen so far. There has been a meta-analysis very recently published from the US, I think it was, where indeed in that meta-analysis, which again is not a study, has been shown that that these results may be as we just included them from the literature, but certainly a nice prospective study would, of course, help us more. So I don't see that coming. So we have to deal with what we have.
Yes, and that brings us to the methodological aspects where Atul was already touching upon, because indeed this is a study only comparing bimekizumab with placebo. We have a short period over placebo. So ideally, we would like to have head-to-head studies. We would like to have a population enriched with a higher likelihood of having flares of uveitis, but we do not have any of them. But that would give us a more definite answer about the efficacy of different molecules on uveitis. But indeed, in the absence of that, I totally agree with your comments, and we have to rely on different data that are out there, cohort studies, observational studies, and acquire experience from that. And one last comment, well, I think you already touched upon it, but maybe Hideto and Atul can give their opinion about that, is whether or not IL-17A and F inhibition will be different than IL-17A inhibition in what concerns the efficacy on uveitis. Can you please comment on that?
Yeah. Yeah. So I one thing we need to basically stress is that IL-17A inhibition or even TNF inhibition does not treat uveitis. This is to prevent recurrence of uveitis. If somebody has acute uveitis, we are going to treat that with steroid drops. The only drug that treats uveitis is steroids, corticosteroid drops. This is to prevent recurrent attacks of uveitis. So in clinic, if I have a patient who has axial spondyloarthritis and they are getting recurrent attacks of uveitis, and I'm managing this patient in collaboration with an ophthalmologist. Currently, I would generally go to the TNF monoclonal antibodies because they are the ones. But then somehow the patient has failed monoclonal antibodies and I'm in a fix now. What am I going to do? Because I need a drug which is going to use, which I want to help both their recurrence of uveitis and or prevention of recurrence of the uveitis and also their AxSpA. I think this would kind of make me think that maybe I might be able to use bimekizumab because the study indicated that might reduce the recurrence of uveitis. So that's the one which I will sort of take home from here. And whether it pans out or not in the future, we don't really know. We know that IL-17A alone, it failed to change. I mean, it didn't really worsen it. Like IL-17A inhibition might worsen somebody's IBD. If somebody's having active IBD, we are certainly not going to give them IL-17A inhibitor. If somebody has uveitis, giving them IL-17A inhibitor may do nothing to their uveitis, subcutaneous IL-17A. This drug, also subcutaneous, may be able to probably prevent further attacks. Again, this being a post-hoc analysis, this just gives us this is hypothesis generating, and I agree with you, Sofia, that a prospective study somehow needs to be done. And it is tricky to do this because uveitis is so rare to occur. Doing studies on acute anterior uveitis prospectively, you need to enrich the population by taking patients who have had multiple attacks of uveitis in the past and then follow them for the next year. A similar study has been done on certolizumab, where patients were with recurrent attacks of uveitis in the last year were enrolled to receive certolizumab and to see what happens to them prospectively and seeing whether and then the comparison is their previous year. It's not comparison with placebo. Comparison is their previous year and then seeing what happens to them. So some similar study will need to be done. The study design is going to be important.
Yes, thank you very much. That was indeed the comment. Hideto, do you want to add something to that?
Yeah, now for the comments. So I totally agree with you, colleagues. And this study did not prove, but clearly suggested the possible effect of bimekizumab on uveitis associated with AxSpA. So it is very interesting, and we are expecting for head-to-head trial. So TNF inhibitors versus bimekizumab or something.
That's a very good point, Hideto, and I'm sure we all agree that that would be a very welcome study. So I think this can bring us to the end of this podcast. So thank you for joining us for this AxSpA podcast brought to you by the Immune-Mediated Inflammatory Disease Forum. And we really hope you find it useful. And if you did, please don't forget to subscribe to our channels on YouTube, SoundCloud, Spotify, or wherever you get your podcasts from. And if you don't want to miss further episodes, just to sign up. And if you want to read more about what we have discussed today, head over to the www.imitforum.com, where you will find summary slides of this paper. See you next time.